This video recording will be on the basic concepts of range of motion and is taken from Norkin and White, Chapter 1. Some basic definitions. First of all, range of motion is the arc of motion at a joint. Active range of motion is the arc of motion attained during unassisted joint motion. This indicates willingness to move, coordination, strength, and joint mobility. Passive range of motion is the arc of motion attained without assistance from the subject. Passive range of motion indicates integrity of joint surfaces and the extensibility of joint capsules, ligaments, muscles, fascia, and skin. Pain during range of motion assessment must be taken into consideration by the PTA. Pain can be due to moving, stretching, pinching of non-contractile structures, or it could be due to pain with stretching of muscles. End feel is the barrier to further motion at the end of range of motion. Normal end feels include soft, firm, and hard or bony. A normal end feel which is soft would be soft tissue approximation such as knee flexion. A firm end feel, which is the most common type felt, is a soft tissue stretch or a capsular stretch. This is due to stretch of muscles, capsules, or ligaments. An example of muscular stretch is a straight leg raise. An example of capsular stretch is MCP joint extension. An example of ligamentous stretch is forearm supination. A hard or bony end feel is bone contacting bone at the end of the range of motion. An example of a normal hard end feel is elbow extension. Abnormal end feels can be soft, firm, hard, or empty. A soft end feel occurs in a joint that is usually firm or hard. The end feel feels boggy, and it's an example of edema or synovitis. A firm end feel, abnormal end feel, indicates increased muscle tonus or shortening of capsules, muscles, ligaments, or fascia. A hard end feel, which is abnormal, is bony grating or a bony block. Examples are chondromalacia, osteoarthritis, loose bodies and joints, myositis ossificans, or a fracture. An empty end feel occurs when there's pain from acute inflammation, bursitis, abscess, fracture, or due to a psychogenic disorder. A joint may be hypomobile. Musculoskeletal reasons for this could be due to shortening or inflammation of joint capsular patterns or non-capsular patterns. Joint capsular patterns can be due to two things. It could either be due to joint effusion or synovial inflammation or capsular fibrosis. Non-capsular patterns involve structures other than the joint capsules. These are joints that rely primarily on ligaments for stability and do not have capsular patterns. Non-capsular patterns indicate the absence of joint reaction, and it usually involves one or two motions in a joint. For examples, it could be internal joint derangement, such as fragments of cartilage or bone, ligament shortening from sprains, muscle strains, spasm, adhesions, contractures, fascia, skin, hematomas, and cysts. Hypermobility is too much movement of a joint. This could be due to laxity of soft tissue, hypotonia, or joint trauma. There are different movements within a joint. A joint can glide, roll, or spin. A decreased motion in a joint can be due to decreased glide, roll, and glide is the most significant motion that is restricted. Slide or glide is a translatory motion in which the same point on the moving joint surface comes in contact with new points on the opposing surface, and all the points on the moving surface travel the same amount of distance. A roll is a rotary motion in which new points on the moving joint surface come in contact with new points on the opposing surface. The axis of rotation has also moved. You can see in this case it moves to the right. Spin is a rotary motion in which all the points on the moving surface rotate around a fixed central axis. The points on the moving joint surface that are closer to the axis of motion will travel a smaller distance than the joints farther from the axis. Now we will talk about the convex-concave rule. If the joint surface of the moving bone is convex, sliding is in the opposite direction to the rolling and angular movement of the bone. If the joint surface of the moving bone is concave, sliding is in the same direction as the rolling and angular movement of the bone. There are different kinds of joints. Synovial joints can be uniaxial, biaxial, or multiaxial. A uniaxial joint has one motion around a single axis in one plane. For example, this could be a hinge joint such as the elbow joint or a pivot joint such as the atlanto-occipital joint. A biaxial joint has movement around two axes in two planes through convex-concave joints. Examples are condyloid joints or saddle joints. Multiaxial joints have movement in three planes around three axes. This includes gliding of carpal joints and ball and socket of the hip joint. Cardinal planes are fixed lines of reference along which the body is divided into equal parts. There are three planes, frontal, sagittal, and transverse, and they are perpendicular to each other. A frontal or coronal plane passes through the body side to side. It divides the body into front and back, and motions include abduction and adduction. Sagittal plane passes through the body from front to back. It divides the body into right and left parts, and flexion and extension occur in this plane. The transverse plane passes through the body horizontally. It divides the body into top and bottom parts. Rotation occurs in the transverse plane. It's also called the horizontal plane. Axes are points that run through the center of a joint around which a body rotates. There are three axes, the frontal, sagittal, and vertical. Joint flexion extension occurs in the sagittal plane around the frontal axis. Abduction adduction occurs in a frontal plane around the sagittal axis. Medial and lateral rotation occur in a transverse plane around the vertical axis. There are 3 degrees of freedom in a joint. A degree of freedom is the number of planes in which a joint can move. A uniaxial joint has 1 degree of freedom, a biaxial joint has 2 degrees of freedom, and a triaxial joint has 3 degrees of freedom. Joints can be positioned so that they are in open or closed pack positions. Closed pack position is the most stable joint position. It's the most congruent position that results in the greatest mechanical stability for that joint. Most of the capsules and ligaments around the joint are taut in the closed pack position. The open pack position is the resting position of joints. This is a position of least joint congruity, position of joint separation, and least joint stability. The positions of travel of a joint away from the closed pack position occur when the capsule and ligaments are not taut. There can be extreme movements in that direction, and this usually results in sprains and strains. Anthropometrics is the science of measuring the human body as to height, weight, and size of component parts, including skin fold thickness, to study and compare the relative proportions under normal and abnormal conditions. The PTA frequently takes circumferential measurements. A common time is when patients have edema or swelling and you want to measure the progression of therapy to see the swelling decrease over time. This is also a picture where you can take circumferential measurements to prepare to make compression garments for a patient. One type of anthropometric measurement which you will do this week in lab is measuring leg length. There is a true versus an apparent leg length discrepancy. The figure on the left shows apparent method where you go from the umbilicus to the medial malleolus. The true method is measuring from the ASIS to the medial malleolus of the same side. You have to be careful when you measure. You need to keep the same method at all times. You should always take 2 to 3 measurements and take the mean of those measurements, and if possible compare measurements between 2 or more clinicians. There may be iliac asymmetries which could mask or accentuate a limb length inequality, and there can be unilateral deviations in the long axis of the lower limb, such as genu varum or valgus, which may mask or accentuate a limb length inequality. Now we're going to talk about muscle length. A muscle is strongest when it's put on a slight stretch prior to contracting. This is called a length-tension relationships. 2 joint muscles frequently do this automatically by stretching over one joint as there's contraction of the muscle over the other joint. Muscle length testing is different. It's the maximal distance between the proximal and distal attachments of muscle to bone. The purpose of testing muscle length is to determine if there is hyper or hypomobility due to the length of the antagonist. Passive insufficiency is an example of a problem with muscle length. This occurs in 2 joint or multiple joints. Active insufficiency is the attempt of the muscle to actively contract. A 2-joint muscle becomes extremely shortened when it attempts to contract over both joints that it crosses at the same time. This is active insufficiency. A couple of examples could be hamstrings with hip extension and knee flexion, and the gastrocnemius with knee flexion and plantar flexion. Passive insufficiency involves muscles that cross 2 joints, and it occurs when a 2-joint muscle is passively stretched over both joints simultaneously. Examples of passive insufficiency would be hamstrings with hip flexion with knee extension, and gastrocnemius with knee extension and dorsiflexion. Here you can see wrist flexors and extensors. Passive insufficiency occurs when the person flexes the wrist so that the extensors are stretched over the wrist and the fingers. Active insufficiency could be active extension of the wrist with stretching of the wrist flexors. Here's another example of active versus passive insufficiency. On the left, the hamstrings are shortened as they attempt to extend the hip and flex the knee at the same time. On the right, the passive insufficiency in the hamstring is indicated by flexion of the hip with extended knee. The next audio tape will go into goniometry and how the process is conducted by the PTA.